At right top, share is there.
Yeah. I just saw there is a.
Yeah, your screen is visible.
Is it visible, the presentation?
Yeah, presentation is visible. You can do it in presentation mode. Yeah,
Yeah, I've already done that.
perfect.
Is it visible now?
Yeah, perfect.
All right.
Perfect.
All right. So, today, you in the workshop, I just read through the topics that a lot of things have been covered with regards to innovations and multiple applications. With that in view, I would like to touch upon something very important and at times less addressed. That is AI in healthcare bridging the gaps. With the advent of any new technology, or there is a change in the system, or there is a change in the spectrum of delivering healthcare or associated things, there is always some lacuna, there are always some gaps, and there are often so many vulnerabilities. And it is our job as doctors, administrators, and policymakers to ensure that whatever is being changed in the healthcare scenario in terms of administration or delivery of healthcare services needs to reach each and every individual, and it has to have an equitable distribution. So here I will be touching upon the gaps. So discussion agenda would be, we will start by mapping the global context, then the Indian context. We'll examine certain barriers, gray zones, misuse, financial feasibilities, ethical legal governance structures, cross sectoral bridges, and then the way forward and vision. So, AI in healthcare is a transformative speed. Probably this has come later, much later than its applicability, the applicability of AI in other spheres, but it was much needed. So to begin with, we need to get at the basics that AI in healthcare, what is it? It is basically an intelligent augmentation of healthcare services and delivery. Then why is it happening? Because the speed at which the changes are taking place, that needs to be addressed. We need to close the gaps in the access of healthcare, the accurate delivery of healthcare, so that there are minimum chances of misdiagnosis, or getting the patients deliver what actually treatment is supposed to be delivered, and the cost factor wherever we can cut down the operational costs, in especially in a resource crunched country like India. So where is it happening? Probably everywhere. As with GPT, Facebook, or any other internet of things, the way it has touched our lives in healthcare, AI is happening everywhere, right from first point contacts in clinics, hospitals, then at the large scale levels in the population health, then the public health. Then we also have the other dimensions, software associated medical devices or software included medical devices, health, wellness apps, and so on and so forth. When is it happening? The time is right now, because currently everything that is fancy is AI. AI is in an inflection decade. And how it is supposed to be done? It is to be done in a manner which gives it a face which is integrated, validated with ethical deployment, and maximize the use of the AI in scenarios where the patient's lives, their health, and the most important things are at stake. So probably we need to have additional safeguards and guardrails in sectors which are especially health related. So, while I was preparing for this, and I'm very thankful to the organizers, because probably because of this presentation and this talk of mine, I developed a lot of perspective and came to know about a lot of things which is actually happening around the world. And it makes me wonder that, we are going ahead leaps and bounds, but what do we need to do? There was a sudden jolt while I was doing it. Probably all are aware there were Cloudflare outages. There were some Cloudflare outages on the 18th of November. And probably this was worldwide. Even systems like down servers and all were down. People couldn't access internet. They could not access their multiple platforms, including Twitter and this GPT, Facebook, etc. So that got me wondering, the systems which are providing us the backbone for the net services or the servers, are we over reliable or over dependent on them? If we are, and of course in today's time, there is a requirement for the same, there is a very important critical element that we need to consider, that is overriding human critical thinking and judgment. This one factor, singular factor, is extremely important. Otherwise, we'll be just slaves of, artificial intelligence and downplaying our natural intelligence. So basically, this jolt made us understand that we need to reimagine equity, equitable distribution, safety, governance, and intelligence for a new era of care. Are we ready for that? Well, we need to have certain systems in place. Coming on to the promise of AI in healthcare, I'm sure we all have been reading and experiencing a lot of tech advancements. But in healthcare, especially, there has been a massive shift, ground and path breaking, I would say, which is the shift from reactive to predictive and precision care. So initially, somebody used to fall sick, the responsible used to come to the doctor or to the clinic, and further on, they used to receive their treatment. It was only if something went wrong, and it was so wrong that it caused a debilitation to them. Next was, but now we are working on predictive and precision care models. If there is an onco patient, we need to give precise medication. The technology for the same is concerned. Then the genomics are there to help predict, and so on and so forth. The applications can be varied. It democratizes expertise across geography. So with the availability of AI, the reach is far-flung, far-fetched, and the best of the things can be available for people who have been largely either disconnected or they have less restraints. Then it does automate routine work. Clinicians, as you know, in India have a very low ratio compared to the patient population, or in terms of preventive health. And a lot of times the clinicians do face clinical burnouts. So the another thing is finances. New economic models and efficiencies have to be instituted if we need to deliver sustainable healthcare. In a country like India, which is a low medium income group company, this AI would help leapfrog us, a country with infrastructure constraints, to deliver the best of the service. Depends how we use it, of course. Then it can be transformative with respect to the evolving needs and the available technologies. The usage of AI across care continuum, that can be in advanced secondary care, where it is already being used for ED triages, that is emergency department, radiology overreads, I think teleradiology and AI in radiology has taken over labs and radiology in a multidimensional way. Of course, there is advent of multimodal AIs, where the text, imaging, genomics all put in together and then give much more precision results. Then there are automated vital scribing and pharmacy optimization. The same is applicable to tertiary care, where in critical care settings, a predictive analysis can be done in terms of sepsis care bundle, prediction of how the sepsis would progress and what would be the prognostication. There are surgical robotics with the machines and all. I'm sure everybody is aware of the navigation techniques for minimally invasive or far invasive, less invasive surgeries. Then oncology decision support system. Uh, it's a part of the clinical decision support system. Now there is a rapid development in oncology in terms of both rad-onc, medical oncology, and surgical oncology. The prediction part, the therapeutic part, and the follow-up part. So these decision support systems would help the healthcare systems, the clinicians, to individualize the precise treatment that can be given, and that may be different for everybody. It is not so that how the nanotechnology or how the decision for either oncology drugs or the newer advents to be given in oncology. So AI would definitely assist in that. Then there are cross-cutting things like command centers, population health AI, of course, at a larger scales, and their role in outbreak prediction and digital epidemiology. So this is a part of the public and preventive health. Another important thing is groundbreaking new feasibilities that includes distributed diagnostic grids. Distributed diagnostic grids, of course, we can work it up with a virtual national tertiary hospital. Cognitive digital twins are already there in the developed countries, and China, of course, has come up with its first digital hospital. Again, it's got similar problems like in India with massive population, and this is definitely great in terms of not only a massive population, but also precise and effective medicine. With digital twins, hospitals and patients, one can uh, follow through and see through various treatment applicabilities without actually harming the patient, or without actually making the patient undergo trials and what can be the outcomes. Cross-lingual multimodal clinical AI for India's languages, autonomous care units, level 1 or 2 monitoring, synthetic data factories for research and development. And of course, when AI is at a massive scale, it is but pertinent to unify all the hospital systems. That is to create an ecosystem where the private hospitals, public hospitals, they all are in the common grid. Currently, the system, as you all know, is small islands. National Federated Learning for Privacy Preserving AI. Again, with the AI and digital healthcare, concerns for data privacy, data ownership, these are relevant contexts which needs to be addressed, especially in a country like ours. Coming on to the global landscape. Internationally, AI is transitioning from isolated tools to integrated clinical ecosystems. There are regulators in developed countries, EU, US, like FDA, which have formulated norms, the governance patterns, which allow which define how AI or machine learning based devices must be monitored. Multimodal, which is a next AI frontier, which integrates text, as I told earlier, images, labs, genomics. But globally, we also see concerns about safety, transparency, equity, and over-reliance. To sum it up, there is excitement, but there is also caution. This has given rise to a lot of global debates on explainability versus accuracy, regulation versus innovation. This becomes extremely important in, again, a country like us, and with the medico legal constraints, which are by far, closely associated with our medical system. So, there needs to be an explainability as to how decisions are taken, the clinical decisions. And again, the liabilities is also a concern. Coming on to international trends and challenges. The global debate now centers around trust, interpretability, and accountability, as I just touched upon. So there has been a trend shift from algorithms to clinical AI ecosystems. There is emphasis on human in the loop frameworks. By human in the loop frameworks is, if entirely the healthcare is autonomous, there are again serious concerns associated with it, and human overrides in all such systems, especially in high risk settings, is pertinent. There are national data platforms, then AI enabled public health, we already talked about. So there are ethical concerns, again, based on bias, cybersecurity, liability, and data colonialism. Bias in terms of representation of society. In statistics, we've all heard about, various kinds of biases. But, the representation of people, the health data has geographical and epidemiological or concerns. So there may be certain gender variations, the ethnicity. There are certain people who are predisposed to certain things. There are certain, tribals or these kind of different segments of people who are to be represented equally, and of course, geopolitical areas. So the nations are now talking about sovereign AI because health data is definitely geopolitically sensitive. Workforces are struggling to keep pace, and regulators are racing to define guardrails while this innovation is happening by leaps and bounds. So globally, this is something which is caught everybody's eye and everybody's working on it. So probably all the nations are into building their domestic health models, which include the foundation models, and further their training. Coming on to the Indian landscape. The Indian landscape is a heterogeneous one. It's a mixed digital terrain. We all have, AI and internet, but the effectivity or the reach where it reaches is varied. The systems are varied. So in India, since it's a heterogeneous picture, we have the world's largest digital health initiative that is creditable by the government, which they've initiated as Ayushman Bharat Digital Mission. So then again, National Digital Health Mission, we've come up with e-hospitals and e-Sanjeevani for the pharmacy part. So these are some creditable steps which we have taken. But again, the another part which needs addressal is the uneven EMR adoption. EMR is electronic medical records. A lot of the data generated is through the medical records. The accuracy, the repeatability of this data, and the interoperability of this data is a concern that needs to be addressed. Definitely, we all are aware that public sector has very limited EMR adoption. There are n number of hospitals, including public and private, where the the hard copies of the hard data that is still prevalent. So it becomes very difficult to associate or to retrieve or to create a continuity of the health data. Then we have high patient volumes, huge disease burdens, and enormous data diversity, which is an opportunity if we structure it. Of course, this is something which is a concern, but definitely there's a huge opportunity we can, I mean, scale on the first league amongst the world in this kind of massive diversity. So the another mixed baggage is there is a diversity in languages, phenotypes, disease burdens. There is a fragmented private sector, and the data standards are very, very inconsistent and sometimes very low. Well, there has been the good part is there has been a lot of innovation uh, in imaging, telemedicine, pathology, and insurance AI. Insurance AI, definitely, it was a need of the hour, and people took great initiatives in processing of the claims. But yes, with the AI in health system coming together, we all need to address these all different islands to make a consolidated one where uh, the people, the patients, the families do not suffer because of their misuse. So there, wherever there is a gap which we will address later, how to bridge these gaps. Coming on to regulatory vacuum. Uh, it's in a very nascent stage, the digital terrain, the healthcare digital terrain. So there is still no comprehensive medical AI framework yet. Very recently, in 2025 only, I think about last month, there have been NABH accreditation standards uh, relating to digital health and AI in healthcare, which have been released. However, they are still baby steps, and the way technology is enhancing is amazing, but the way it is being integrated, it's still a lot to be done. There are certain India-specific barriers and solution. Again, barriers would be multilingual data sets. Again, we have a huge opportunity here, and we need to have our own foundational data sets. There is a huge rural-urban digital divide, which is a gap and needs to be addressed for comprehensive, scalable, and equitable distribution. Fragmented EMR systems I already touched upon, and healthcare in India in general is varied. There are hospitals which are quaternary care hospitals with n number of funding, and there are low resource setups, including government setups or including other small corporate or medium-sized setups, the secondary level care. So the initial cost benefit ratio break even has to be seen, and there has to be a consistent policy move in that direction. Then there is a vendor lock-in risk. Vendor lock-in risk. The people who are the companies who are giving these systems or the AI tools or SAMDs or SIMDs, software associated medical devices. So again, it should not happen that the hospital or the organization is stuck with these vendors and there are certain concerns which are not addressed, including their um, things like the new software it comes, the new development in the disease patterns, or how the data is being used. Then there are workforce resistance as well. Or there are besides having a multiple skill mix in hospitals, there is also one challenge where whenever there is a change, there is some resistance to it. Change management has never been easy, and it is just how well this change is managed, since it is at a large scale and affecting global and each and every Indian here. So these things need to be addressed in a sensitive manner. Then there are certain unique opportunities. Uh, India has the largest data set potential, as we talked about, and it's but incumbent upon us to train sovereign Indian medical models. Sovereign is, I mean, we all give it a contextual framework from a territorial one, but yes, Indian sovereignty is really required. To give an example, I would just say taking some defense equipment or aircrafts from the foreign nations, and when we want to use it, the sovereignty at times are concerns. We always have to depend. The dependency is the constraint, and the usage of the data would be a constraint. Then India, though, has become the world's leading hub of ethical, scalable, frugal AI. Our population is large, it's genetically diverse, multilingual, and clinically complex, which is ideal for training powerful models. So here we have a, I would say, sovereign advantage over many other EU and EU nations and United States, for that matter, or even we can be competitors to China. Our healthcare work, our healthcare workforce is overstretched. AI can be a workforce multiplier. We have both the need and the opportunity. So, AI as a force multiplier, we've already talked about. Uh, Preventive AI for non-communicable diseases, it's a heavy population. As we are looking at the statistics, there has been a massive rise in non-communicable diseases, especially lifestyle-associated diseases, which includes diabetes, hypertension, strokes, cardiac diseases. And most of the admissions and later ICU admissions have been related to um, long-term sequelae or consequences of these disease conditions. So, targeting the population at preventive level would, I think, be one of the best things that we can do for the humanity as such. Then there is AI-driven population health surveillance. Health surveillance, again, it is a preventive part, and again, epidemiological tool also to see the outbreaks of epidemics, etc. And again, cost efficient, frugal innovations, and probably India is doing much great in this. So coming on to a comparative landscape, just to give an idea, as we compare the, a little developed regions like EU and US, China and India, as far as the domain regulation is concerned, there is maturity, much better than the others, with the governance standards, the policy standards per se, and the audit systems. In China, this regulation has been fast and state driven. Probably China has, as is evident, they've already started their first AI hospitals and all that. But let's see how it goes and how we can learn from the countries who have already adopted and are evolving into this. India, as far as regulation is concerned, I would say it is in an evolving nascent stage where a lot has to be done, and multiple ministries across the government need to sit together, including academicians and policy makers. The data infrastructure is very strong in EU, especially China, EU and US, and it's large scale in China and very, very fragmented in India. Use cases, there are clearly defined areas with clarity where the AI is used. So the definition of the problem is very strong in countries which are more mature in this area, EU and US. Then China has gone about, like us, having a population scale with a massive population scale and addressing the issues of accessibility. Uh, India, again, it's still in baby stages, but of course, nonetheless, we are doing a lot in teleradiology. We are doing it in imaging, image reading, and labs, etc. Along with triage and screening, there are challenges. The challenges which are there in the EU US are in terms of liabilities, accountabilities. Should there be a problem that there is a consequence or a sequelae of treatment or management decision which causes a problem in the patient, who is liable? The hospital, the doctor, the clinical decision support system, the vendor, the AI company, what? So that's a loop which needs to be addressed. China, again, there is a transparency, which is a transparency issue. Probably that is one of the things that uh, they need to show to the world. Then in India, cost constraints and capacity building. These are two things that are probably the rate limiting steps. The opportunities are immense for all the three. For all the three kind of nations. There is an enterprise AI, medical AI in EU US, which is evolving at an exponential rate. China, the scalability is there, the opportunity. And in India, we've already started, although frugal, but innovation is there. Coming on to the gaps, the gap map. The biggest challenge is not technology. It is bridging the gaps between islands in the system. There are isolated islands in terms of technology, in terms of clinical practice, in terms of policymakers, implementers, vendors, the so on and so forth. So these are the islands which need to be bridged. So to touch upon that, I'll be coming on shortly. Data is fragmented. Clinicians are not trained. Vendor push black box systems. Black box systems are really, opaque systems where you don't know what you're getting into, especially with AI. Policymakers are slower than innovations. Innovations are probably working at an exponential rate, and we have to catch up. As policymakers, we need to catch up. Patients are often digitally excluded, and bridging these gaps is, I think, the only key to responsible AI adoption in healthcare. So to touch upon briefly gaps between technology and clinical practice, which includes EMR fragmentation. How do you connect EMR from one hospital to the other? There is no way. How this EMR goes to the national registry. So there is probably a need from the umbrella system at the national level to state system to the hospitals and their interoperability. Poor data quality and interoperability, as I touched upon. There are lack of structured data sets. So there is a standardization which needs to happen in the data sets. Otherwise, the kind of data which is to be analyzed would be a poor interpreted data. So that may affect the results later on because all the results are based on whatever inputs we are giving in. Then there is not a very high literacy among clinicians, I would say. And the workforce resistance, of course, this is more manifest in government sectors, but even in the private sector, cost may be one of the constraints. There are gaps between policymakers and implementers. There is a very slow regulation. There are no audit frameworks and unclear liability. There are gaps between hospitals and vendors. At times, there are misaligned incentives. Of course, the vendors want to push through black box systems, and the algorithms, which at times the hospitals may not even know their explainability or interpretability may be a problem, and how the new versions or the models develop, that may be a concern. Then there is a definite lack of shared governance models. So governance has to be a joint governance in areas where we are dependent on other systems. So bridging these two islands. There are gaps between patients and digital systems. There is very low digital literacy, as I told. Consent misunderstandings may be there. Consent misunderstandings maybe in terms of the procedural consents, like what procedure we are undergoing, or there may be consent misunderstandings about the usage of the digital system. There's a very interesting example. uh, Whenever we take a new site, go to a new site or a new app, there is about 16 17 pages of agreed to conditions and terms, and how many of us do really read that, and we just sign it without knowing where the data is going, and what all we do not agree to. So maybe 10 or 20% people maybe who are digitally sound or technologically, they are very aware, they may be using it, but in terms of general people, including myself, it at times we really forego that. So that can lead to a lot of misunderstandings and later on litigations. Then accessibility barriers. So there we have rural, elderly population, low income groups. For them, making this technology available to them needs certain additional systems in place. Then data infrastructure interoperability. Just to give you a statistic, there is less than 20% of EHR penetration. EHR is electronic health records, siloed private sector data, weak coding standards. By coding standards, which we do include the ICD standards, a lot of times, whenever a patient is treated upon, there are certain international classification of diseases standards or codes, ICD codes. So they are used, and if there is these are technical ones, so at times the code may vary, and it's the patient who suffers then. This is particularly relevant in people who are being awarded disabilities, or otherwise their insurance claims, or that can cause a lot of problems. Then cybersecurity vulnerabilities we are all aware of, and this data can be misused by unfair elements, both at the national and the international arenas. But coming on to Ayushman Bharat Digital Mission, though it's a very smart step the government has taken, it's a backbone of now what is to come. Uh, there is, however, very strong state level execution which is to be rolled out to see that it delivers what it is expected to deliver, and how also to advance it further. Then there are certain gray zones and unresolved questions. These gray zones are the uncomfortable areas that nobody wants to talk about. Uh, who is responsible when AI's output lead to harms? That is the clinical liability for AI assisted decisions. That is a concern we need to address. Should high stakes triage be automated? Again, the thing is that, again, human in the loop interference should be there. Model drifts, as you know, in other AI assisted or deep learning things, or even in simple things like iPhones, there's a model drift. There is a degradation after deployment of such things. So after a while, newer thing comes up which has additional features or which has additional penetration to disease or something. Again, biases that may have unfair outcomes for vulnerable groups. We need to address this very consistently because that can affect, the already marginalized groups, and that may depend on the incomes, the gender, and the age. Then there is explainability paradox. So, in AI, whenever we are more concerned about the accuracy, the less it is explained. So, the more the AI tries to explain it, the accuracy definitely would uh, decrease. However, from a clinician's perspective or the hospital's perspective, the explainability has to be higher. uh, Also, it doesn't mean that we do not need accuracy, but explainability, because of the liabilities, medical legal liabilities, is very, very important. Then another challenge that we have here is unregulated AI light tools behaving like medical devices. So now you see there's so many apps which have come. They see your blood glucose levels. I'm just giving an example. You see your blood glucose in the app, and then they modify the insulin requirements or the dose requirements. So these systems are totally unregulated, and the kind of havoc we may face is of an enormous amount. Then there are dual use risks. The AI that is being used, or this thing that can be misused by insurers or employers. And not only AI, the health apps, the digital platforms, which are of course unregulated. How the data is being used may insurance is about money, and how it can be misused can be fathomed by our imagination. And already there is a lot of concern amongst the general population about denial of claims, etc., and how this medical information or health information can be used for prediction or behavioral analysis needs to be addressed at probably the highest levels. Coming on to some emerging gray zones. Who owns medical data used during training of these AI training and foundational models? Can hospitals really deploy AI without institutional review board or ethical clearance? Again, in the current scenario, it has to go through an IRB or ethical clearance. Should AI be allowed in high stakes triage? There has to be human override, and not in high stake triages, because where this element, autonomous element, could cause some problem. Uh, Autonomous radiology reads, is it permissible or unsafe? Again, and in the current state, there has to be human in the loop. Predictive analysis, a lot of treat outcomes do depend on, rather majority do depend on the diagnostics, and if there is an error in the same, then we are bound to head for a disaster. So that's the reason. Then the predictive analytics for prognosis, does it cause psychological harm? When prognostication is done, prognostication in a live patient, to the relatives in a condition where the patient is sick, there's a lot of emotional burden and emotional trauma that the family suffers. Based on data and predictive standards, uh, you never know whether it is going to cause a psychological harm, increase fatalism, or the depression, or at times you never know the credibility of the data. What I'm talking of is in the current scenario. So these are all interrelated gaps. That is why human in the loop, or these things are very, very important. And it's not only automation or use of AI, it has to be an intelligent application of AI, sorry. So adaptive AI self-learning, how to certify version changes. To give you a simple example, ChatGPT has evolved over a period of time. So the version changes are as far as the digital platform is concerned is fine. But when it comes to healthcare, if the autonomous AI system is adapting or auto regulating or sorry, auto evolving or self learning, uh, who will certify these version changes? So that's an important concern. Then there are shadow clinical AI, which is used informally by the staff for governance purposes. Again, this infringe upon the privacy, and the same has to be curtailed. Of course, the misuse potential is very, very high with very, very high stakes. Coming on to the dark health web and its potential for abuse. Where there is data, there is power. We all know that. And where there is power, there is bound to be misuse. It's been over centuries, and nothing is new in today's times. Insurers may deny coverage using predictive analysis. There is a possibility of insurance misuse, where the risk scoring may be done by the companies to have unfair premium hikes. There may be automated claim rejections. They may be identifying costly patients so as to avoid them. Uh, Corporate misuse. Um, Again, corporates can cross-link behavioral and health data, uh, cross-linking with health and financial profiles, and stealth nudging for drug sales. So, these are the gray areas, though the corporate where they can misuse the common public. Government misuse. Uh, Something about the surveillance. The government can use health data for surveillance and predictive policing. Then the cyber crimes. Cyber crimes in the health is pertaining to genomic data, and that can have far fleeting consequences. Then cyber criminals target hospitals with ransomware, and we need early guardrails before this dark web grows, and we need to be evolving in our predicaments so as to curtail at each and every evolving dark web state. So again, to sort of identify the risk and how to bridge it, there is a health data re-identification. We need to have robust data protection law. Illegal medical models sold online, penalties for unauthorized AI deployment, employer surveillance, for which a national AI registry may be used, behavioral micromanagement, human override clauses in high-risk systems, algorithmic redlining. Their whistleblower protection is used. Synthetic data, I'll just stop a little while for algorithmic redlining. There always have been across centuries redlining or marginalization of certain sections of the society, and they may be basically generally the either the oppressed or either the low income groups or either the illiterate ones who require a lot of protection or who require a lot of support systems. So it needs to be seen that these redlining checks don't happen in AI, and the whistleblowers in the organization, healthcare setups, or the government, they need to be protected if such thing is brought to light. Then synthetic identity fraud via medical data. Again, this is only one can fathom. It can be dangerous. So strong cybersecurity and audit systems. Coming on to digital health apps. Again, these are some things which are of great concern as of now because they are floating around across the internet and people are using it upright and center without any regulation. So they maybe the classification for the same may be low risk wellness apps, moderate risk health guidance apps, You've seen apps like Healthify Me, Fitify, or all those kinds of apps. Then high risk medical apps, software assisted medical devices, like where blood pressures or blood glucose levels or stroke kind of things are identified, and then treatments optimized on the digital platform where regulation is sketchy. There are certification requirements which need to be undertaken. These again can be done by the government agencies or the regulatory bodies. Mandatory audits, user data transparency statements, ban on behavioral profiling. Then remote monitor benefits or bane, digital health apps. Benefits include remote monitoring. Definitely, we can remotely monitor a lot of things. This can be utilized. This is a strength. Improved adherence, again, it is a strength. Population level analytics can be devised, probably the data is correct. And democratizing of the knowledge. These factors can help scale and sustain the healthcare delivery process. However, the risks that are associated are also not to be overlooked. There may be zero medical oversight for these digital health apps. Self-diagnosis leads to harms. Of course, the people may not seek medical attention where it has to be sought. Unregulated mental health apps are influencing the emotions, and this is now spread across not only to the children or adolescents, but across all age groups. Selling user data, sleep, heart rate, steps, insurers to advertisers. So again, how this data can be used can be left to imagination. Shadow profiling and behavioral prediction. Um, then we've discussed about these fitness and metabolic apps. How the strengths would also increase access in underserved areas. Then enable continuity of care, empower self-managed chronic diseases, integrated system checks, teleconsultations, diagnostics, and increased screen reach via smartphones or AI-based. So the penetration and the accessibility reach would be high. However, they come with a cost. The data harvesting can be done by these and can be sold to dark web or for commercialization purposes or for tracking to various agencies. Health misinformation may be amplified by poor quality apps, as there have been multiple instances. I'm sure you must have come across various cases where people have gone to the net and probably deteriorated and taking the advice or have caused them immense harm. Over reliance by patients, bypassing the clinicians, fragmentation, multiple apps, no unified record, algorithmic nudging. As you know, as happens, we've all seen in Facebook and YouTube, there is an algorithmic nudging where behavioral manipulation is done, and unregulated wellness apps, they're behaving like medical devices. So strong regulation is required now. This is the time. So bridging this gap can be through certification framework for clinical apps, privacy by design requirements, and clear demarcation, medical versus wellness apps, multi-language explainability, mandatory disclosure of data use, model intent, and offline capability, and low data user interface for rural users. In our setting, though people know how to use the mobile phones, but the user interface has to be very strong. There are still people who go to the physical places to deposit their bills or this thing, because still the user interfaces, though the agencies are trying to really simplify them, but for our rural and for our technologically challenged population, that becomes a problem. Coming on to health economics and feasibility in for India, why it works for India. There are workforce shortages. AI can magnify capacity. There's 30 to 60% reduction in diagnostics or triage, 8 to 12% operational savings, 20 to 30% reduction in tertiary load via AI telemed. Financial risks include high initial digital infrastructure cost, lack of reimbursement models, AI rich versus AI poor inequality risk. This is the equitable equity risk that we face off. So, in a country like us, these things have to be addressed in a systematic manner. So, the feasible LMIC model, low medium income group countries, would include maybe pay per use AI, that is between say of the hospital or the healthcare organization or the government involvement, maybe government pool infrastructure and resource pooling. Then local manufacturing is the solution. Of course, when we have to buy things or export things, they come at a cost. And cloud optimization. Feasible LMIC model would also include high impact, low cost AI for conditions like TB, maternal care, NADs. That is the non communicable diseases. Here we can directly at the preventive aspect as well as follow ups. Any issues that might arise can be addressed, and the involvement of teleradiology or telediagnostics for the same. In a resource constrained setting like us, we have the capex cost, that is a capital expenditure, which include infrastructure, cybersecurity, the operational costs for implementing these programs, including staffing, informatics, model audits, cloud storage, etc. Savings and gains would be faster diagnostics, reduced errors and litigations. That saves a lot of money and time, better resource utilization and allocation, predictive maintenance, and shorter length of stay in the hospitals. Of course, there are n number of problems that are associated with the longer length of stay in the hospital, including the patient deteriorating further because of contacting healthcare associated infections and cost that goes in maintaining the patient and the psychological effects. The risks can be that AI can increase inequality if only expensive hospitals adopt it. So this inequality, if it comes, it will cause a lot of problems between the haves and the have-nots. Coming on to AI Readiness Index. In India, it can be broadly seen at 6 levels, whether we are infrastructurally ready in terms of servers, electronic medical records, cloud, cybersecurity, the data readiness, structured data sets, annotation quality. Again, there has to be a national level framework for these things, both in terms of policy, governance, and auditing. Workforce readiness, that is clinician literacy, technical staffing. Coming on to governance readiness, regulations, audits, liability clarity. Financial readiness, budgets, grants, incentives for the adoption, as well as making these things available. Then the cultural readiness on the part of both these all the stakeholders, basically building of trust, adoption behaviors, transparency. Each hospital state can be benchmarked. Coming on to AI first hospital maturity model. This is a very self-explanatory slide. At level 0, we can see digitally dark hospitals or healthcare organizations where none of it is actually implemented or started. At level 1, we can say there are at least some generation of EMR and basic automation. So things like lab information system or medical records are there. Level 2 would be where there is an application of clinical decision support system, where the AI would help in supporting or augmenting decisions, clinical decisions. Level 3 would be predictive analytics and integration. Level 4 would be an AI ecosystem with interoperability. And level 5 would be autonomous systems with safety oversight. We have a long way to go, but the best part about AI is that the maturity is fast. The only rate limiting step would be governance and implementation. modes. Coming on to AI roadmap as a national perspective, we've already in phase one, we've done it. Digital backbone, ABDM, that is the Ayushman Bharat Digital Mission. We have ICD coding in place, electronic health records are being done at large. At least digitization has started in a lot of hospitals, including public sector. Phase two, high value AI, where imaging, triage, TB, non communicable disease is done. Phase three would be predictive health, where genomics and precision care is given. This is, of course, in very large quaternary care and very few in India. And phase four are the intelligent systems, digital twins, autonomous systems. And phase five, continuous learning, federated national AI. Coming on to bridging the silos or the bridging of the gaps. There is a need for a resilient AI health system. Excuse me. A resilient AI health system requires bridges between technology developers and clinicians, as we discussed about, clinicians and administrators and policymakers, insurance and ethical boards. I think we touched upon all of them. Medical education and industry, that will come about later. Government and private sector, public health, hospitals, and patients and digital systems. Without any of these, or without even one of them being addressed, the system is bound to fail. So basically, AI cannot succeed in healthcare unless the full ecosystem collaborates. Technology alone would not be able to solve the entire healthcare problems, especially in the AI background. And every stakeholder needs to come on board. So the onboarding is process systems, which needs to be taken care of. Coming on to certain intersectoral bridges, like we discussed for technology and medicine, we need to have a co-development and clinical AI evaluation labs. Bridge 2 would be between finance and healthcare, cost effectiveness modeling, innovative financing. Bridge 3 would be insurance and healthcare, again, ethics and human in the loop claim decisions. Education and policy, well, there has to be AI curriculum, state capacity building, administrators, policymakers, AI procurement standards need to be impeccable, and we need to have readiness levels which is appropriate and up to the mark. Bridge 6 would be public and health system, trust building, communication, and transparency dashboards. So, India's AI health bridge system includes at a national level, then that is basically proposed, and then India's health data grid, federated learning network, and AI ready workforce programs. Then innovation is something which is being done in India at multiple levels. However, there needs to be tech hubs, including IITs, AIMS, and ICMR. Probably IIT Bombay is running a fantastic program on this, and AIMS Delhi and IIT Delhi have collaborated. There is also an interesting development about 2 to 3 years back, where one of the IITs has set up its own medical college, a 100-bed hospital, where the medical technology gaps can be addressed. So that's one of the frontier and a very good initiative that has been taken up. Fair AI insurance charter. Again, this is extremely important because health now is based on insurance, and out-of-pocket expenses would be a far-fetched dream. Hence, in these times, high value, low-cost AI for countries like us. Now, getting on to the last mile, the accessibility gap. Again, we need to address where AI can fail. The rural and the tribal regions. So, as we discussed, AI tools which are offline, consume low power, and has a friendly user interface. Elderly population, local language, voice first interfaces. Women with limited digital access. This is the sad reality, still prevalent. So AI supported ASHA, ANM ASHAs, the auxiliary healthcare workers, and auxiliary nurse midwife, which are there in the villages as a part of National Health Mission. So they can be of real support. Low digital literacy groups, where low cost phone based diagnostics and public digital literacy campaigns. Then, person with disabilities lacking adaptive interfaces. Then, government subsidies and digital literacy can be inculcated for these people. If Braille can happen, probably AI Braille can also happen. That's just the need of the hour, and probably somebody is going to do it. So, that is what innovation is all about. Insurance optimization versus exploitation. Again, I wanted to touch upon this because this is one area where people are going to be jarred. AI driven premium discrimination. So, for this, we need to bridge the gap, and national fair use regulations need to be in place. Automated claim denials may happen. So, again, human in the loop and ban on AI on denial of coverage, predictive exclusion of high risk individuals. So, once the data sets are there, so insurance companies can always have this data and exclude high risk individuals. So that is there, and AI explainability needs to be there for all insurance decision denials or excluding high risk. Misuse of lifestyle or app data, again a concern in today's times. The capped differential pricing and financial nudging disguised as health advice. Joint oversight with clinicians, patient groups, insurance participation in transparent sandboxes. Definitely. Now, NMC is the National Medical Commission, and should it be included in the curriculum? Yes, in various phases. And we need to have an AI competent clinician as a standard of care. They should be knowing about cybersecurity. So, this can only happen once we include all of this in the curriculum of medical education. India's digital health constitution is based on patients' rights, transparency, explainability standards, safety monitoring system, model audit trails, insurance misuse safeguards, cross-border data protection, public ownership of critical health data. Now, a framework for responsible AI as part of the governance and ethics would include autonomy, beneficence, benefit for the majority, non-maleficence, no malified intent or no harm, justice in delivering care, transparency, fairness, accountability, explainability for the decisions, uh, human override. Goes without saying, and we've stressed on it quite a number of times. Data minimization and purpose limited use. This is very important, especially with the dark health web and the digital apps and the treatments that we are going to follow, or the insurance data. Shared legal accountability amongst various stakeholders, drift monitoring and periodic revalidation of these systems, national AI incident reporting system, what we can measure, we can see where there are problems, adverse events, we need to bring out the solutions and also disseminate the results for the same, and reversibility. So for this, we need to have an India-specific governance blueprint with the national authority, hospital clinical safety committees, biomedical data sets consortiums, ethical guardrails, no AI-based denial of care, no coercive nudging, multi-language explainability, protection for vulnerable groups. And as far as the governance architecture for India is concerned, there is a policymaker's stake. Key functions would include certification of AI tools, monitor performance, mandate audits, investigate AI linked harm, oversee adaptive models, and ensure patient rights. Coming on to algorithmic sovereignty for India, I think all the nations are working very hard and very strong on this. So, India, with its vast data sets and the varied data sets, it needs to have its own things in place, systems in place, medical foundation models, data pipelines, clinical AI governance standards. This is important, although we have started taking baby steps towards the same as far as accreditation of hospitals is concerned, digital accreditation. Then avoidance of vendor lock-ins, foreign dependency, and data extraction by global platforms. Again, this is a dark reality which we need to address at various levels. Human in the loop framework. Category A, I'll just cover the broad categories. AI-assisted, low risk, where only vital triage administrative workflows. AI-guided, which is medium risk, diagnostics, risk prediction, treatment prioritization. Category C would be recommended. AI recommended decisions, they are high risk, including surgical planning, chemotherapy regimens. So the guardrails have to be high. High care requires mandatory human sign off, human in the loop that we talk of. Workforce transformation has to be fast and ensured. We need to understand AI is an augmentation, not replacement. Newer clinical roles, clinical AI operators, or clinical AI physicians. Data literacy should be included as an essential competency and avoid clinical de-skilling. Nothing is as important as the clinical skills that the doctors possess. So we cannot outsource everything on AI, and this competency should not be de-skilled at any time. AI integrated CMEs and simulation-led training. AI for public health, again for outbreak prediction, etc. Emergency response modeling. This ties AI to national priorities as well. Coming on to way forward, bridging the gaps. There has to be one national AI safety and ethics law. Actually, the way forward is a combination of regulation, education, financial planning, basically the systems we've talked about, safety oversights, systems in place, and innovations. For that, we need national AI safety and ethics law, algorithm registries, audits, uh, public-private partnerships, academic coalitions, infrastructural investments, bias testing, uh, a community AI literacy, insurance regulation, reinforcement, and basically the governance and the implementation. And with all this, a transparency mandates. So, this gives also an opportunity to us to be one of the pioneers and one of the strong contenders in the world of AI in healthcare. And India can lead the world. AI-enabled primary care at every which can be out of the box thing. Tele-robotic surgeries for rural districts, seamless lifelong electronic health records, AI guided care, autonomous ambulances, drone logistics. This is especially being used for drug deliveries. And we have a large population, large data sets, and goes without saying that we can have great foundation models. Zero preventable deaths in maternal and child health, AI for climate health adaptation, and India is a global leader in ethical, inclusive AI for health. So, but for all this to happen, we need to ensure that the future is ethical, equitable, accessible, and with sovereignty. Coming on to the way forward, there is a strategic path which we broadly covered, which is at the level of foundational digital infrastructure, which includes EHR coding standards, develop transparent, equity-focused models, ensure policy regulation, make AI affordable and accessible, professionalize the AI workforce, establish multi-sectoral bridges, tech, medicine, finance, etc. Promote responsible innovation. So take care of sandboxes, and then we are into digital twin, synthetic data, and federated learning. So, with the entire discussion, I would like to say that with an aligned governance, the national policy which has to be in place, and the basically the efforts from the government, the focus from the government, equity and intent, healthcare can become proactive. with the availability of AI, India can reduce catastrophic health expenditure, which is beneficial both for the patients, the country as such. The rural urban divide can narrow, insurance becomes transparent and just, medical education becomes futuristic, hospitals evolve into intelligent learning ecosystems. And India can lead the world in ethical, frugal AI for health. And with all this, I would like to say that AI is not just to replace clinicians. It is here to empower them and with the changing times and living in the times, make the best what can be there for the uh, people of our country. So with this, I finish my presentation. And should there be any questions, I'd be happy to answer. Probably I've taken a lot of your time. It was probably an exhausting one. So thank you all for your patience.
Thank you, ma'am. So from the participant side, if any question is there. So, ma'am, I have one question. Like you have presented many gaps and many challenges of AI in healthcare.
Yeah.
So, can you cite a few example of AI tools or AI software which are currently used by the clinician or currently used in clinical practice? And can you cite they are fulfilling those challenges or they are about to fulfill or like what is the scenario actually? I just want to know what is the current scenario of the AI software which are being deployed in the hospital or so can you comment on this?
All right. So basically, first, this thing is how we are currently in the state of technology usage of these things. So a lot of algorithmic thing is already on, which is there in radiology. There is a domain specific thing. Domain specifics may include radiology, lab, or certain areas of ICUs or oncology, where these models, after studying lakhs of images and all, I'm sure teleradiology and all, AI radiology you've seen. So based on algorithms and image reads, they are given. So this is at one level. The second thing is there are various models which are used as a part of multimodal diagnostic AIs. These combine, now these are complex models. Uh, they are at preliminary stages, and not many hospitals are using it. So again, like I talked about AIMS, I talked about IIT hospitals and the memorandum of understandings. There have been multiple memorandum of understandings which have been signed between various institutes of evidence, both medical and technological, where multimodal diagnostic AI is being used in imaging, clinical notes, genomics, prediction in oncology. To know which exact softwares or models are used, I think I would have to check on that, because the names I would not know. But yes, the models are there and they are being used. Then, yes, again, in ICUs, again, clinical decision support system models are being used. So they have a very specific role. What they are doing is generally prediction of deterioration models, like sepsis prediction. There are multiple things which go on in the ICUs. One of the challenge that patients in the ICU faces, where they're critically sick. Sepsis is one thing which can happen, and that may, be a predictor as to, or a prognosticator as how the patient is going to have a quality of life, or whether he's having a guarded prognosis. So this kind of a thing can be the model which are currently in use. Between 6 to 12 hours they can predict that how the sepsis is going to predict progress, or how that this patient can or sepsis. Then there are certain things like in some of the hospitals, again quaternary hospitals, we have AI usage in ventilator settings. So again in country like ours where a lot of patients are there in ICUs, so AI assisted ventilator settings. So this is a very beautiful thing that normally the intensivists they see, and there are very few intensivists who are looking at the patients, and for the very few intensivists for a large number of people in the ICU. You cannot have one intensivist for one patient. So this monitoring system and that is taken over by the AI. Or it's not that the intensivist is not there, but they would the AI would tell that this person saturation is this, or depending upon the clinical indicator, various scoring systems that have been in the algorithm, that this is the amount of PEEP, that पॉजिटिव एंड एक्सपिरेटरी प्रेशर वगैरह, ये इसको इतना देना है, SIMV में इतना रखना है. So these advanced technological settings can be assisted by the AI, and it is being done, though at a very very small level. These are as far as the clinical things goes. Lab, okay, again in histopathology, that is what kind of slide pattern pathology, histopathology. So the diagnosis after can be made a little more accurately, not a little more, a lot of accuracy can be there in identifying and removing the blind spots where some of the clinicians can face. So that there the AI is being used, and it is being used in pathology, radiology, and ICU. Coming on to it's definitely being used in operational models and for operations and
कोई प्रॉब्लम्स आ रही है, हार्डेस्ट प्रॉब्लम तो अभी तक जिस पे रिसर्च चल रही है, ठीक है, उनका कैटेगरी करके उसको एनालाइज करो क्या, ठीक है, यू कैन.
So, ma'am, your voice is breaking, I think. Hello? Hello? Can you hear me?
Actually, I couldn't hear anything because the voice was cracked. Can I just
Yeah. Now it's yeah. Actually, there was some network issue. Okay. So we understand this AI is currently at that initial level where the assistance is provided by the AI systems to the doctors, and they can get the benefit of the AI, but not at the critical level, but at the initial level and for the assistance level. And
absolutely.
later on with the use of responsible AI that may touch the another level of assistance. So in that way, it will be forwarded.
Absolutely.
Okay, thank you, ma'am. Thank you for explaining the various types of gaps for deploying AI devices in healthcare. And you have presented a universal picture of the implementation of development needs of AI in healthcare. Surely it will be helpful for the participant to understand the different challenges in healthcare while using the AI devices or in the real implementation of AI softwares in hospital. So thank you, ma'am. Thank you very much. Thank you for accepting our invitation, and thank you for delivering such a nice lecture. Thank you, ma'am.
Thank you so much. Okay.
So now, participants, we will have a short break of 5 minutes. So after that, we will get back to the another lecture. So we will join back by 11:38, right? So please join by 11:38. We will start the another lecture. Thank you.